Radiology and Medical Imaging, and tonight we'd like to talk about advances in MRI revolutionizing the treatment of prostate cancer. We're very proud and thrilled, actually, happy to have one of the world leaders in pioneering, a visionary, looking at how imaging can help our clinical colleagues, the urological surgeon, the oncologist, and the radiation oncologist, sort out the dilemma which for many, many patients, and in our community here in Southern California, the big dilemma of anybody reading in the newspapers, the dilemma of the high PSA. What does it mean? How do we handle this? And there's a raging debate going on, and if anybody in the world could come and help us sort out a way through this morass, it is Dr. Yeli Barnes. And really, why did we bring Yeli from his peaceful, beautiful forest home in the outskirts of Holland in the Netherlands somewhere, all the way to California? Why would he come here? It's because he has a passionate belief that there is a new way forward. An elevated PSA does not mean you have cancer. It also does not mean you need the dreaded trust biopsy. It does mean, though, possibly, and I'm thinking more and more we can be more dogmatic about this, but you do and will need at least an excellent screening MRI. But not any MRI, because just like there are many different cars, you can have a jalopy from 1965 or a Testarossa. I saw a Bugatti outside. I don't know if you all saw that. It's not always necessary to have a Bugatti, but you'd better make sure you have a scanner that is at least as good as a decent late model BMW. So these types of MRIs are multi-parametric MRIs that are generally high field, which means 3T, and you really need to have the sophisticated capabilities to do diffusion-weighted imaging, as well as ADC maps and dynamic contrast enhancement, and have the sophisticated software which Yeli will talk to us about tonight. Over here we can see a classic example of a prostate cancer that, with the ability to do DWI imaging with a B-value of 1400, calculated B-value that most scanners can't do, and the concurrent ADC maps showing the restricted diffusion, you can sort out whether a lesion is a cancer or not. So our commitment to our patients is that we will have at Medical Imaging, which is on Wilshire Boulevard, a stone's throw from here to our community, the finest in service. We will care for you. We have the patients' advocates, a lot of the ladies you might have met in our team, some of the guys as well. They're usually not as nice as the ladies, but just my biased opinion. But they're all good, even the guys. And basically, the fact that we can have the highest quality radiology interpretation with the relationship we have with Yeli in the Netherlands, with the help of technology that allows every single prostate done at our facility to be read and double read by 2 radiologists. So the right equipment, the right team, in a compassionate environment, my commitment to you. With that, I'd like to invite Yeli to come and talk to us and enlighten us on the new way forward. Yeli got his medical degree at Utrecht University in the Netherlands. He did his fellowship and training at the University of Nijmegen University of Radboud actually in Nijmegen, and has for 20 years dedicated himself like nobody else on the planet to understanding what is the best way to find that carcinoma in the prostate and then figure out how to not only find it, but fix it. Thank you, Yeli. It's all yours.
Thank you, Brad, for this very kind and nice introduction. Thank you for being here. I hope that I will be able to bring over some of my enthusiasm to you. It's a mixed audience, which is always a little bit of a challenge to a speaker. There are top experts in prostate MR, there are top urologists, top medical oncologists, and last but not least, there are patients. So I try to give a talk which fulfills the need of all. Advances in MR revolutionizing the treatment of prostate cancer. Why should we care? Breast cancer strikes 1 in 7 women, and they have a mammogram. Prostate cancer, dear gentlemen, is 1 out of 6. And the question is, where is our mammogram? Okay, we should do something about that. Everybody knows the pink ribbon, and only you now in this room here know about the blue ribbon. It's not only a thing which is important to this guy, who's the patient, but also to his son and his grandson, because they want to ensure that their granddaddy and father leads a happy life without the problems of incontinence, impotence, or without the worry about his PSA. So it is important. Again, where is our mammogram? I will show you this evening that we have the mammogram there. Why do we need good imaging? Because of this patient. To be or not to be? That is his question. And we can help him. That is why I've chosen in my professional career to go for oncology and the last 15 years to prostate cancer, because we can make a difference as radiologists. Prostate cancer MRI is increasing. I call it a tsunami. The number of examinations is now tenfold from what it was in 2005. These are the numbers of prostate MRs which we are doing in our single institution in Nijmegen. 2,500 this year. And the black bars are the direct MR in-bore biopsy techniques. The techniques which assures you, as I will show, to hit the most aggressive part of the tumor. Almost 500 patients. And you see it is going down a little because there are new techniques have been used at this moment, which is MR transfusion. I will come to that a little later. So, with prostate MR has been there already for 20 years. So why is it now that prostate MR is breaking through? Because we are facing a paradigm shift. In the early days of MR imaging, everybody was focused on staging extracapsular disease, which is important, but more important is, do you as a patient have prostate cancer? And if you have a cancer, is it a significant cancer? That's what you want to know. So detection instead of staging. We used to have a very complicated 2-hour MRI, endorectal coil spectroscopy. We don't want to have that. It should be simple and fast. No more than 30 minutes or even shorter. So no endorectal coil, no spectroscopy. A paradigm shift. The other thing is, and that is a paradigm shift between urology and radiology. Most people see this as a turf battle. I see this as a collaboration opportunity. That we should do MR-guided biopsy, MR-driven biopsy, instead of random cross biopsy. And finally, if we know where the tumor is, if we can biopsy it with a needle, we can also do minimal invasive MR-guided therapy. That is what I want to show in the next 45 minutes. Multiparametric MRI, Brad already told it, it is a BMW or a Volkswagen. You should have a good car, not a very expensive car, but it should fulfill certain rules. We have the T2-weighted technique, which is for anatomy. It has been there already for 15 years, but recently we have the fusion-weighted imaging for biology, dynamic contrast-enhanced MRI for vascularity, and spectroscopic imaging for metabolic information. Now let's see what these techniques can do. Anatomy. This is an anatomical section through the prostate, and you can see very nicely the central part of the prostate, the transition zone. You can see the peripheral zone, and this is a beautiful image. of the Netter Atlas. Now, it is not in color, but you can see that MRI almost beats this beautiful image. You can see the peripheral zone being white with the strands of fibrotic tissue. You can see the transition zone. In this patient, it starts to be enlarged because at my age on, it will enlarge due to benign prostatic hyperplasia. So you can see this image nicely matches this very nice, colorful anatomy. And when we see something like this over here, a dark structure, it can be cancer, especially if it is pointed out by a red arrow. Low signal intensity, however, doesn't mean that it is cancer. It can also be blood due to previous biopsy. It can be inflammation, or it can be benign prostatic hyperplasia. So we need more, and that is the paradigm shift. Recently we got a technique called diffusion-weighted imaging. You're looking at the motion of water molecules in between the cells and in the cells. And if they move freely, the speed is high, it's white on the image. However, if you have dense, tightly packed cells, the motion of water molecule is reduced and you will see a black hole. This is quantitative information which you can acquire. So this is a tumor. This technique provides specificity and gives information about tumor aggression. But you can see that this is a rather unsharp image. The resolution, the sharpness is not good enough. So you should use it in conjunction to T2 or perhaps with contrast, because tumor has an increased vascular permeability. So it shows uptake of a contrast agent. On the other hand, also other structures like benign prostatic hyperplasia and prostatitis, so inflammation, do enhance. So it provides sensitivity but not specificity. Now we have a good anatomic technique, we have a very specific technique, diffusion, and we have contrast. So this three will do it all. Then the question arises of my academic colleagues, what about spectroscopy? Spectroscopy is not a BMW, it is for Ferrari drivers only. Why? It's costing a lot of money, it is beautiful to do, it's a boy's dream, a radiologist's dream. However, you need experience how to drive. This is what happens if you are a Romanian soccer player and if you do not know how to drive a Ferrari. You have to buy a new one. Okay, experience. And that is what is lacking in common practice. So, spectroscopy is good. It's a very fast car, but you need to be a Formula 1 driver to get fast from A to B, and you don't need to have traffic jams, otherwise it won't work at all. Now, as a radiologist, you should listen to your colleagues, the medical oncologist, the radiation oncologist, the urologist, and they should tell me what they want to know, to learn, to see what the patient has. And these are the questions which I will address this evening. Can multiparametric MRI improve localization and detection? Can it assess tumor aggression? Can it improve local staging? And what about the tiny lymph nodes? Okay, let's start with number 1. We have prostate-specific antigen. Brett already told that prostate-specific antigen is a test which not necessarily is meaning that you have prostate cancer. And I call it a little bit different. I call it prostate-specific anxiety. Because if you have the test and if your PSA is elevated, you're anxious. My PSA is elevated. Oh God, what should I do? I should go to a urologist. And well, yeah, you may be one out of the 10 who has an aggressive cancer. However, 8 men don't have an aggressive cancer. They have benign disease, which causes the PSA elevation. And 1 out of the 10 has an insignificant cancer. So it doesn't necessarily mean that you have prostate cancer. Nonetheless, if your PSA is elevated, if you're concerned, the urologist will do a thrust biopsy with 12 needles. And needles cannot be avoided, however, the number can be reduced. The other thing, what you can do is use your finger to feel the tumor. However, tumors at the anterior part, away from the rectum, you can't feel. Specificity is good, but sensitivity is low. And I always make a joke that the finger of the urologist hasn't eyes, but I have MRIs. Now, when the finger is gone, and when the PSA is being tested, the next step is, if you have a concern, PSA anxiety, you have the 12 needles. And the 12 needles are being put into your prostate with so-called transrectal ultrasound. You see the prostate, but discrimination of tumor with ultrasound is rather difficult. So there are some limitations, and I call it the 40-40-40% rule. First of all, a significant cancer which is anteriorly located most often is not seen by ultrasound and not being biopsied, so it's missed. This is true in about 40% of cases. Second, if the diagnosis of cancer is there, how sure are you that you have biopsied the most rotten place of the apple? This is a Gleason 3+3, that means you don't have a very aggressive cancer. This is the Gleason 7, 3+4 or 4+3. This is the aggressive part. This tumor you should treat. This tumor, perhaps, can be, followed by active surveillance. It's about 40%. Underestimation of tumor grade. I will come to that a little later. Finally, if you stick in a needle at random, you may find a tumor which is insignificant. And if I ask you, if I tell you, yes sir, you have an insignificant cancer, what word do you remember? Insignificant cancer. Well, I have cancer. Oh, I know. Yes, I can remove my prostate by a urologist. Perhaps I should do that. Or active surveillance. The anxiety starts. And many men will have their prostatectomy finally done with a chance of having incontinence and impotence. So this is actually the reason that we do not advise at this moment for PSA screening. The overdiagnosis and subsequent overtreatment. I will come to that a little later. So the challenge of multiparametric MRI is, can we show the exact location of the most aggressive part of the tumor? And can the number of biopsy cores be decreased and its yield increased? We will never get rid of the biopsies, but can the number be decreased? And of course, I will show that the answer is yes, yes. Limitations, significant cancer being missed. Let's look at this man. This man is followed by 5 years, and his PSA was 5 years ago. It's now 28, and every year, and in total, he had 96 cores of biopsy, still negative. And then you make this MRI. You say, oh, this is a not so sharp image. Okay, let's have a look. This part is benign prostatic hyperplasia. That's what we know from anatomy. This part is dark. It should be as bright as this part here. This is the peripheral zone. The peripheral zone is darkened. So the question is, why is that? And finally, you have another dark area over there. Now let's look at the blue area, the darkened area of the peripheral zone. This is behind the so-called 1.7 centimeter line. And what is this magic line? This magic line is the length of the biopsy needle of the urologist. So this patient had 96 needles here, causing fibrosis at the posterior part of the prostate, but not giving the diagnosis because there was absolutely no tumor in this region. Now, what about this region here? Okay, T2, it can be anything. So use other techniques. Diffusion, black. Restriction, high cell density, enhancement. So this is most probably an aggressive cancer. What to do next? Another 12 needles, transperineally, or saturation biopsy? Why not do another 50 needles? You can do that, that's for sure. Or stick in a needle deeper. Okay, what we do is MR-guided biopsy. We have a pen, like the thickness of my finger. You can see it here. This is the bladder, this is the prostate, this is the rectum. You see very tight, a pen like here. This is this structure. It is hollow, and we point it towards a lesion, and then finally, we shoot a needle. And this patient had a tumor with a Gleason score of 4+3, which means he has a significant cancer, which was subsequently treated by radiotherapy, and this patient now is cured. Now the question is, why do you miss this lesion with TRUS biopsy? Well, with TRUS biopsy, you actually biopsy only this part of the prostate. This is the lateral view, so you look at the patient like this, from the lateral side. So this is the bladder, the front side. This is the rectum, you see the pubic bone. This is the prostate, seminal vesicle, as you see here. And with TRUS biopsy, only this part is being biopsied. So an anterior tumor or a tumor at the base or even at the apex can be missed. So we need to do something, and the best way to do that is with MR guidance. What about the value of this technique? The literature shows that the biopsy rate, the positive yield of biopsy, is in between 37 and 59% in patients who have had a previous negative TRUS biopsy. So that was negative, still concerned, patient had an MRI, you can see many alters, and you can see that the detection rate is quite good. Now, in brackets here, there are percentages. These are the percentages of significant cancers. So you see that we detect cancers, but predominantly significant cancers. That's good news, because we do not want to detect the insignificant cancers. We want to detect the bad guys. Now, you can do a direct in-bore in the MR biopsy. That's good. Brad can do it. Not yet, but he has to learn it, or his team. Joe Bush can do it, but not too many radiologists can do that. So, how to bring this information now to the urologist? Because he doesn't like the MR bore. He needs to have long arms, and MR is, well, with magnetic things. You don't like it, do you? You want to have something in your office with ultrasound. Well, good news. We do have MR ultrasound fusion. However, the bad news is we are not there yet. It will be there, but not there yet. Or we can give you the MR. Say, okay, the MR is here. I stick in a needle, boom, boom, boom. So, MR TRUS image is available. Or we just can tell you it's at the anterior part, so that is MR in your head. That is what we call cognitive fusion. And you can understand that the accuracy is increasing from here to there. Now let's look at the MR TRUS fusion, because this is something which is now being enormously advocated by companies, and urologists like it, but the requirements are that you merge the information of ultrasound and MRI in a correct way. And if you do not calculate the surroundings of the prostate, which is called segmentation, accurately, you will have an error. Also, if you stick in a needle or an ultrasound transducer into the prostate, it deforms. It's not a rubber ball, it's more like a tomato. If you press into a tomato, the shape changes, and that causes an inaccuracy. And you will not miss the tumor, but you will miss the hot spot, the most aggressive part. It has been calculated by our group, and it's published, that to hit the hot spot, the inaccuracy of this technique should not exceed 2 millimeters. And at this moment, data from the companies who are producing these tools are not there yet. So you have to be careful. You may miss the hot spot. MR biopsy is considered to be long-lasting, expensive, takes a long time, 1 hour in the magnet. So we are looking for fancy things. We would like to do MR fluoroscopy. That means follow the movement of the needle guide. You see the needle guide over here. This is the lateral view. This is the axial view, the needle guide here. And now we are moving the needle guide manually in 2 directions. We point it from this side to that side, and you can see that automatically the machine is following the stick. We call it a dog machine follows stick. So it's following the stick. Okay. The other thing is you have to walk in and out of the room, so we need to have a robot, a remote control thing which we can steer sitting behind the console. And that thing is almost there. This is the remote control manipulator. It has the size of about like this. You can see the stick here, and this can be steered from remote control. So what you can do is sit behind the console, and you, just like a PlayStation, you move the stick into the position, you make a confirmation image, and then you shoot a needle. Safe and accurate and time consuming. We can do 3 patients per hour using this machine. Whoops, I go back a bit. I can show you how it works. Remotely you can see the stick move from one side to the other side. I will repeat it again. You can see it move. You press a button and you can just steer it. This is the stick, and we are targeting the stick towards the prostate lesion over there. So let's go back now to the presentation. Can we determine aggression? Let's have a look. With diffusion-weighted imaging, there is a correlation between the speed of water molecules, the ADC value, and aggression. This is normal. This is insignificant cancer, low grade, intermediate grade, high grade. And this is the ADC value. It goes down. So there is a correlation between tumor aggression and the value on ADC. We even can draw a line between insignificant and significant. There is some overlap, but this works pretty good in practice. How does it look at the image? If you see something like this, it's nothing, it's insignificant. However, if you see a black hole, this is a very aggressive tumor. So, it's nice. What about the underestimation of the cancer grade, which is also a problem? We did a study in which we compared truss biopsy with MR, multiparametric MRI biopsy, versus the gold standard, that is the tissue removed from the patient, so the prostatectomy. And then we compared what's the outcome of the biopsy in tumor aggression versus the outcome of the prostate tissue. And we have seen that the ultrasound biopsy, echobiop in Dutch, it's 54%, the accuracy of the true Gleason, the highest Gleason grade, the most aggressive part, whereas with MRI it's 95%. So there is a significant difference. Also, MRI has been shown to have a very high so-called negative predictive value for significant cancer. So no is no. If we say no, it's no. Well, in 3% of cases we're wrong, but okay. This is pretty good for a technique. Now we can use this information for active surveillance, potentially for screening, and for focal therapy, because we can identify the index lesion. Active surveillance. We did a trial, the prospective randomized international active surveillance trial, and what we did is patients who were, according to TRUSS, eligible for active surveillance. So with TRUSS there was a low-grade tumor. We restaged them and evaluated the tumor aggression with MRI, and in 14% of cases we saw that there was a more aggressive tumor than with TRUSS. So MRI upgraded the tumors in 14%. What happens after 1 year? Well, MRI and TRUSS biopsy were equal. So that's good news. Probably you can save TRUSS biopsies by just doing MR imaging. Now let's assume you have a Gleason 3+3 tumor, and the MRI shows 3+3, that's good. What nowadays people do is they have a needle every year, or once in 2 years, to have your diagnosis assessed, but you cannot be quite sure. Now with MR imaging, you come to my office and I show you nicely, you see, there's no tumor. And after 1 year, you can see that there are no changes. Will you go home happily? Probably yes. If there is a change, however, we can stick the needle exactly to the point where the change is of the image. Screening, big issue. Overdiagnosis of insignificant cancer limits PSA screening. And there even are now organizations, the urologists and also the GPs, they advised against PSA screening. But PSA itself is good because you can detect significant cancer. So why should we throw it away? However, screening is being advised against. It has a yield of mortality reduction and less metastatic disease. However, too many biopsies without cancer and in 40% unneeded treatment. Now with MR imaging, you see that you have the right treatment in aggressive cancer, lower cost, as I will show you later, and also you have an 8-fold less needle and you have less unneeded treatment. So I think that in the future, potentially, PSA plus MRI may solve the screening dilemma. Of course, you need to validate these things. And a lot of urologists say to me, okay, this is nice, Jelle, but can you validate it? Do you have data? Okay, we did a study in Brisbane, Australia. There was a very enthusiastic urologist who came to our place, and we learned him and his team the technique. And then we did an evaluation. He said, Jelle, I want to run a study. So we discussed the study, and he actually had a patient population with elevated PSA, naive, so that means no biopsies before, only elevated PSA, and all the patients underwent the routine TRUSS biopsy, 12 needles. And they all agreed in having an MRI. And the MRI was interpreted, so was read with the so-called PIRATS criteria, objective criteria. And all the men with a suspicion of prostate cancer, that means PIRATS 4 and 5, they had an MR-guided biopsy. Now, first of all, patient without a suspicion on prostate cancer. That was 51 or more than 50% of all the patients. And if you choose for this strategy versus trust, it will reduce the number of biopsies by 50%. In the US, that will reduce the number of biopsies by 500,000 men per year. What about priorities 4 and 5? Okay. First of all, the number of needle calls in total was reduced by 85%. So a lot less needles. Good news. Second, the number of insignificant cancers was reduced, the detection, by 90%. So we missed them. And that's good. Because we do not want to see the insignificant cancers. Because those cancers will not kill you. So in the entire population, the absolute risk when you do TRUS to detect an insignificant cancer was 21. And that went down to 2%. Of course, urologists then will say, yeah, but you do not biopsy in pilots 1, 2, and 3, so you will miss significant cancers. The answer is yes. However, the negative predictive value appeared to be 97%. And with TRUS biopsy, you miss more cancers. So the number of significant cancers detected even increased. The negative predictive value of TRUS biopsy is 71% versus 97% of MRI. So you detect even more significant cancers. And finally, they did the cost calculation. The reduction of unnecessary surgery yielded a cost reduction of per patient of more than $700. And there was a quality of life increasement. That means that the patients were more happy. Less complications, less anxiety. Okay, to be continued. Focal therapy. Now let's assume you have breast cancer. And your surgeon says, okay, I will remove your other breast as well. What do you say to the surgeon? Is that really necessary? No, okay. Okay, now let's assume you have prostate cancer. And the urologist say, well, we can't rule out multifocal disease, Joe. So what do you say? Can I have an appointment? Of course, you will say, I would like an MRI. But most men will say, I will have my prostate removed. Now let's assume you're a neuroradiologist, Brad. Let's assume you have a brain tumor. And your surgeon says, okay, Brad, it's good. You may have a tumor on the other side. Let's remove your entire brain. So, the good thing is, it's not for you, but most men are thinking with a prostate. So, okay. So why should we remove the entire prostate? In the years of breast cancer, 20 years ago, if you have breast cancer, there was mastectomy. You know what it means? Breast tissue, skin tissue, muscle, everything was gone. So, now, in 20 years, we learned that more focal therapy, so focal ablation, removal of the tumor with subsequent radiation of the resection margins is a better technique. So why don't we use it for prostate? Well, we didn't have imaging modalities, but now we have. So focal therapy, focal radiotherapy. Here's the tumor, so do it focally. Less doses on this part of the prostate, more on this part. This gives cure and less side effects. But we have other techniques as well. We have focal MR laser. This patient has a dark lesion on the fusion, enhances smudgy appearance. This is a bad tumor. It appeared to be a Gleason 4+3. This patient agreed to volunteer to have laser first and then prostatectomy. And we wanted to show that laser was very accurate. So I will show you the results of this patient. Here you see the stick, which is usually used for the biopsy needle, but now you can put in a laser fiber. And what you see, and I will restart the video, so get back to this point. What you can measure is the temperature at the tip of the laser. And this is the killing zone. This patient had an outpatient procedure, local anesthesia, one needle, and we burned away the tumor. Then of course the question is this accurate enough? And what about the agreement of the laser versus what we saw on the image afterwards? You see a black hole versus the prostatectomy specimen. You can see that the orange part, the killing zone, exactly matches the tumor which was, the part of the tumor which was burned away. This potentially can be used in the future as an outpatient procedure. Work in progress, to be continued. What about radiotherapy recurrence? If you have a tumor back after radiotherapy, it's terrible because surgery is a very difficult job. The tumor is as solid as rock, and the surgeon has to cut with his knife through the solid tissue. So this patient has here his prostate, and this is a recurrence. What you can do in these cases, in the Netherlands we did 60 cases, you can do cryo-MR ablation, cryotherapy. You put in a few needles. This patient had radio seeds, but here you can see the needles. And then what you can do is you can freeze, shape an ice ball. You can see the shape of an ice ball here. This is done in a period of 6 minutes. You actually can monitor it very good. This artifact is caused by the fact that they opened the door of the MR room. They closed it again, they opened it again. One of the first procedures, so everybody wanted to look. So, but this is the ice ball. And this is the killing area of the MRI. This is the ice ball, this is the prostate. So no whole gland ablation, no local ablation. This is the lateral view, urinary bladder, ice ball, like a popsicle. And the nice thing is we can put a balloon in the rectum with warm water, preserving this crucial area, which is the rectal wall, and preserving this area, which is the area of the neurovascular bundle. The gradient, the freezing gradient using a warm water and ice ball is steeper, so you can be more accurate and you can do more than we're not using this. With ultrasound cryo that has been done before, this is impossible because you don't have the possibility to fill the rectum with the balloon because you have to put in the endorectal probe for ultrasound. We did 60 cases until now. We had 3 recurrences. A recurrence you can retreat again. So this is before, and this is the situation after. No vascularity anymore. So this patient had a successful cryo. A few words on local staging. Because of the paradigm shift, I'm just showing one patient. Don't forget it. This patient, young man, sexually active, PSA elevated, bad tumor on biopsy. You can see black on ADC, Gleason 4+3. This is an intermediate grade tumor. And the urologist said to this patient, "Dear sir, it's not good. I feel something which is not good. So I have to remove your neurovascular bundle because I feel something in your prostate at that side." So you can see the tumor over here. I will highlight it. This is a tumor. Okay, now the neurovascular bundle is more to this side over here, the lateral side. So after the MRI, we told the patient to try to find a good surgeon who is willing to try to see whether he can just save the neurovascular bundle. That's what was done, and this patient had minimal extracapsular disease. The resection margins were free, and this patient had, after this, a very good and active sexual life. So it can happen. This is an endorectal coil MRI. We only perform it if minimal invasion matters, because it has a high sensitivity and specificity. Now, talk about the small guys, those damn lymph nodes. Why do I say damn lymph nodes? Because we are not good in detecting lymph nodes, I'm afraid. An enlarged lymph node can be normal, and here, this small lymph node can be positive. So, what can we do? Go to surgery, but that's more invasively, more costly, and it has a limited coverage. It also misses the small, tiny metastasis deep in the pelvis. It's very difficult behind the vessels. So, surgical exploration is not good. Conventional imaging is not good. The sensitivity is really very poor. So what should we do? Once in a time, we had Combidexin syndrome. Rust water, iron oxide particles coated with a dextran. And life appeared to be very good, because this iron is being eaten up by the so-called macrophages after injection. So the macrophages contain iron. They go to normal lymphatic tissue. That's where they are. You see, they're full of iron, and they disturb the magnetic field, so this is black. Whereas the metastasis remains white. That's good for a radiologist. So, normal lymph node, abnormal lymph node, without iron, white, white, with iron, black, white. Now, if you suppress the background also, you only have to look at the white light bulbs. Joe, you're sitting at the first row on purpose. How many positive lymph nodes do you see, and where are they? You got 10 seconds, because on the next image you will have even less time to do that. And time is money. 9, 8, 10. Okay. Here, there, this one? Okay. And now? Okay. You missed this one. This was a normal one. This is an abnormal one. Now what we can do is we can colorize those lymph nodes. Make them red, make them green. And now I'd like to see a movie. We can, for the radiation oncologist, plot this. CT with MR fusion. Combidex, diseased lymph nodes over there. Let's go back to the image again. You can see diseased lymph nodes, and the size of the lymph nodes in this patient was only 3 millimeters. Imagine that's about this. And you can see them. And what you then can tell to the radiation oncologist is, do selective radiation. This patient was cured. So life seemed very good. However, nice studies. Sensitivity increases with this technique. Fantastic. However, there were some problems with the registration and financial issues, economical crisis, and as of April the 1st, 2010, Combidex did not exist anymore. Now, okay, first let's consider what did we learn from the nice time that we had Combidex. We learned that routine lymph node dissection, the green area, is the area where the urologists are finding lymph nodes. In the rest, it is difficult. So positive lymph nodes were missed in about 40%. Deep in the pelvis, behind the common iliac vessels, that's the tricky area even for a urologist. And urologists are considering now doing extended lymph node dissection, remove everything here in the pelvis, but that has risks. The other thing as a radiation oncologist, they try to blast away the tumor with radiation. However, in patients with prostate cancer, in 50 to 61%, lymph nodes are outside of there. That's what they call RTOG, clinical target volume, the radiation area. So also they miss the lymph nodes. That's why lymph nodes are the damn lymph nodes. If you would know, however, where the lymph nodes are, you could do dose painting and do selective radiation. However, it was stopped. How to continue? Other techniques, diffusion-weighted techniques, work perfectly well in the local prostate. However, in small lymph nodes, it's not that good. 66% positive predictive value, but 75% of lymph nodes were already large. So it doesn't really work good with small lymph nodes. Now we have other things like PET-CT traces, radioactive isotopes, which selectively go to diseased areas. So is that a solution? MR lymphography in the same patients, more positive lymph nodes in more patients with a much smaller size compared to 11C choline PET-CT, which is being advocated as the solution at this moment. And it's better than nothing. But this technique, which at this moment unfortunately doesn't exist, is even better. Now this is a nice, interesting graph. This shows you the positive lymph nodes in this patient population, with PET red and with MR blue. And you can see that it's equal up to 7 millimeters, but below, PET is not that good. Why? Because you need to have a certain amount of tracer to be seen. And what you also can see is that about 50% of lymph nodes, this group here, metastases, are in lymph nodes which are smaller than 5 millimeters. A problem. Another iron oxide particle. Rust water is rust water, so why shouldn't we use the other one? Ferromoxytol, approved for anemia, off-label use. Okay, this is Combidex, this is ferromoxytol, same patients. Look at the abnormal lymph nodes. This is the signal intensity, so this is bright, this is dark. This is reference tissue. Now look at the negative, positive lymph nodes. So they contain cancer, no iron. That's bright, and it's bright. It's about equal. But now let's look at the negative lymph nodes without cancer. They should be dark due to the macrophages. Ferromoxytol, Combidex. And with Combidex you can draw a line between normal, black, abnormal, white. And here's overlap. That means that it's not bad, but it has a limited specificity. You may have false positive lymph nodes, and you may radiate too many lymph nodes. Okay. Never ever give up. Winston Churchill. And they call me the crazy Dutchman. So, yes, I'm the crazy Dutchman. So, what we did is, our department of radiology, we bought the entire stuff from AMEC Pharma. So, Combidex is in our possession. We hired the man, the cook, who made it, Jerry Lewis, and we are making now the agent. And under the Dutch law, if we can exactly reproduce Combidex in my country, I can use it in any patient I want. So we're going to use it as of January 2014 in patients with any cancer, breast cancer, prostate cancer. That's step one. Step two is I'm not in industry, so I'm not interested really in earning money. So we will have a discussion with colleagues, with the FDA, with the EMEA, to see whether we can get this agent approved within the next 5 years. I even will fly to Russia in 2 weeks to see whether we can get it in Russia approved faster than the rest of the world. Look for opportunities. This is the phoenix. It has arisen from the iron dust. The MR imaging is the most sensitive tool available for imaging prostate cancer. This has been stated by one of the leading urologists in Europe. However, what's this guy doing? He's using MRI. Very precise technique. Okay. In Germany it's called the Wasserrutsche. Okay, what's this guy going to do? This is how urologists look upon multiparametric MRI. Oops. Okay. Too good to be true. This should be fake. Okay. The crazy Dutchman. It's not me. I'd rather do MRI. Okay, congratulations. We saved the patient a biopsy. Good. Now, too good to be true? Can we do it? No. Axel Heidenreich, chairman of the EAU Guideline Committee Prostate Cancer. It's very expensive. It is very expensive. MRI is costing $3 million. Okay. Talk about money, euros. Okay. This is the strategy of a patient with an elevated PSA with MRI, and this with trust biopsy. So you can see you do MRI in the subsequent steps. False positive, false negative, treatment options, and if you fill all the options in here, with the sensitivity and specificity you find out in the Netherlands, where we do not charge per core biopsy, but just general. So in the US probably this amount is a lot more expensive the more biopsies you do. You have decreased costs, $150, this is euros, and you have increased quality of life. That means that this is a dominant, cost-effective technique. It is a little bit more expensive in the beginning, but it saves, in the end, more cost. Provided the fact that the urologist is not doing, based on MRI, if you don't detect a tumor, you will not do a prostatectomy, and he's not doing just random biopsies. Now, there's another thing. There's no consensus among radiologists. So, Brad, can you do a good MRI? Or another radiologist. Now, let's see. I see this too often. This is a patient. You see his age, elevated PSA. Urologist didn't find a tumor. And then all of a sudden, a radiologist says, this is something that is not good. And it's black on diffusion. This is cancer. Suboptimal MRI, not according to the guidelines. Suboptimal interpretation. A direct transperineal biopsy revealed benign prostatic hyperplasia, which is not a surprise, isn't it, Joe? Why isn't this a surprise to you?
Where's the other parameters too?
Okay, good. I will show you. I will give you a demonstration on this patient.
And what's the AGC?
Virtual toolbox. This is the patient. This is what you like, don't you, Joe? T2. Anatomy. Anatomy from the side. A big prostate. You can see his urinary bladder here. This is the prostate. Pubic bone. Rectum. Big prostate. And what you like, Joe, is, of course, the enhancement image, the diffusion image, and the so-called p-value, which is an enhancement of the diffusion image. And now let's make a journey through the prostate. This is how we work. And actually, I can steer this computer from here in my office in Nijmegen. So let's look at this patient. We go up, 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 up. And there's the tumor. Okay, let's go to the tumor. Oh, sorry. Again, the black dot here. And I told you that a black dot means high cell density. Now, if you look at this image, the borders are sharp. It's not smudgy. Also here, the borders are rather sharp. So, if you score this patient, and you should do this systematically, by that system, 1 is normal, 5 is abnormal, you say, okay, add finding. There's circle the T2. How would you score this, Joe? The 2. Where's the lesion located? It's about here at the apex. And perhaps a little bit, no, on the other side, I made the mistake. It's over here, and a bit over here. And what about the DCE? Curve type 2. How many points?
2.
I agree. What about diffusion? Black and white? 5.
Yeah.
Now, the final score is because anatomy in this part of the prostate, and that's what we learned is the most important thing, the final score is the T2 score, which gives you the Pirate's final score of 2, which is likely to be benign prostatic hyperplasia. Now you say save, and you can print this now, and you also can see that in this patient, there is an area here with a score of Joe Bush and Yellow Barons 2, 2, 5. Now let's go up. Let's go up. Okay, Joe. What do you think about this area? Enhancing a bit. It is perhaps a little bit focal. Let's have a look a little bit up and down. Okay, this is here a focal lesion. You can see that, and I will move this cursor. You can see that there's something going on over here. This is white. This is dark. Dark here. Score T2? 3 or 4? Oh, you give it a 4. Okay, let's go.
What's the ABC value?
I'm not there yet, Joe. You're too fast. You're a non-academic radiologist. I take time. Okay. A 4. Contrast. Not much, isn't it? 2. And diffusion? What's diffusion? Okay. The ADC value, Joe, is 1248. It is not bright and it's not white. So forget it. That means 2? Yeah? Final score? 2. Okay, now I will show you a thing which I did hide for you. What does it mean, a white spot? You see a white spot in a T1 weighted image. Hematoma. Okay, so this was blood after a biopsy. You can see that even with blood after biopsy, we have the right diagnosis. So this is no tumor. Okay, where is it located? It was located over here. Click, click. And we say save. Now, this patient must have a tumor, doesn't he? Let's go up. Let's go up. Does anybody... Okay. Not Joe. Is there a radiologist in the audience who does see a tumor? Give you an extra drink if you're right. Ah, Joe, the extra drink is for you.
Okay.
Please point out a tumor and tell me what your score is.
Can I have a drink first?
No. You can't drink before you make a diagnosis.
It's fine to look where people miss, so you always look out and I feel right, I feel in the anterior right there.
That's black. Okay.
Black.
You want to know the value?
Black.
Yeah.
It's going to have a high ADC value.
The value is 600, it's even 590.
Yes,
That's too low. It's below 950.
that's 7.
Okay, and here? It's bright, isn't it? And what about a T2?
There you go.
Yeah, lenticular shape. It's bulging a little bit outwards. I can move a little bit up and down. And now I would like to show you here and zoom it in. It's a nice thing about this tool. You can see here an area. This is the tumor, bulging out a little bit. It is just below the bladder wall. And this you score as at finding. T2, a 5. It's located, by the way, over here. You score a 5 on contrast. It doesn't do anything. On diffusion, it's a 5. So this is Pirates 5. The type is tumor. MR-guided biopsy revealed a Gleason 7 tumor. Now, you can see here the scorings. And also what you can do is you can add info. You can measure the prostate and get the measurements here. You can put in the PSA value, which was 28, 27, 28, and you can calculate the volume of the prostate and the so-called PSA density. If that's above 0.15 or 0.20, I'm concerned.
Yeah, even though the anterior, what would you say about the capsule breaking up, right?
Yeah, that's a tricky thing. 1 means nothing. 3 means yes. I would give this, I'm a little bit of a coward, I would give this a 2. It's a visual report, it's a little bit bulging, there's broad contact with surface, so there may be extra capsular disease. The question is that important for the urologist? Is that important for you to know that it is a little bit outside of that area? Probably not, because you resect it anyhow. With your robotic surgery, probably you go here, you enter from here, you go into the bladder, go up, and then to the seminal vesicle. So if it's below, near the sphincter, it would be more difficult. Okay. Experience does matter. That's what we've seen. A lot of my colleagues are unaware, incompetent. Those are the worst radiologists you can have. Experts going to a meeting in France to learn more about prostate had only an agreement of 30% compared to the true experts. And this meeting and other meetings made them aware incompetent. That's good. They know the limitations. And we all have areas in life where we are aware incompetent, and this then should result in aware competent. That's how we should tackle my colleagues. So we need guidelines. Education, certification, quality control. Guidelines, indications, that we should do that with the urologist. How to acquire images. There's a technician here as well in the room. So it is important to acquire good images, isn't it? And you can improve quality, can't you? Your techs came to our place, they learned how to do it, they went back, they brought it to practice, and they constantly got feedback by Jelle Barends and others. And that improved the quality. Acquisition. MRI should be good, simple and fast. No 2-hour exam. In detection, 5% of our patients, to detect significant cancer, it takes 25 minutes. If you have a clinical MRI in staging, it's a little bit longer. Sometimes you need the endorectal coil, but no more than 40 minutes. And finally, in our country, we only do node and bone protocol. That means we only are evaluating the nodes and the bone if there is a clinical suspicion, high PSA, high tumor aggression, or the finger which feels a tumor. Because those are the criteria that urologists are doing a bone scan. So don't image node and bone in patients with a low PSA, low glycin, or nothing at the finger. Interpretation. Is this the young lady or the old lady? It's subjective. I always make a little bit of fun when you have a boarding party of radiologists, give them an image. And they will be discussing that image for hours and hours and hours, until the late hours. Because, okay, interpretation is subjective. Old lady, young girl. Same patient. So, we have been copying what radiologists did with breast imaging. Nothing new. In breast imaging, we have the BIRADS, we here have the PIRADS, Prostate Imaging and Reporting Archiving Data System. We did an initial publication, and the aim was to standardize the interpretation and reporting of multiparametric MRI to compare inter-observer variability, you and I, and reduce this variability, because if you say it's a 2, a 3, and a 2, and I say it's a 4, a 5, and a 3, we can discuss why are you saying that it is different from what I do. So we can reduce the variability, and we can now discuss the individual scores. It also enhanced the communication with our clinicians. If we see PIRADS 4 and 5, it should be a significant cancer. That's important. Quality assurance, we can compare. Objectively, I can compare how you perform versus how I perform. And we can do research. And finally, this will definitely improve patient outcome. In the United Kingdom, structured reporting is being enforced by the government in oncology. It is a 5-point scale of a probability of a significant cancer. And dear radiologist, I don't want to detect cancer, I want to detect significant cancer. So it's not for extracapsular disease, it's not for insignificant cancer. You have a score for the various modalities, and just for radiologists, this is the T2. And if there is disease outside of the prostate, like here, or like there, or like there, it is a 5. It's all described in this paper. If you see something in the prostate like this, or something like that, it's a 5. Also described over there. If it's reduced, black and white on the fusion, it's a 5. So in this way, we can just put the diagnosis into just data. Now, another thing is, this is for radiologists only, is that I would like to stimulate you to use high B values which you can calculate. This is a tumor, and you see the higher you go, the more bright this is. Nobody, even at the last row, will miss this tumor. This is cancer. And you can even reduce all of the prostate and have only the tumor visible. Something new. So we can enhance our diagnosis. Radiologist, it's not a sum score, adding everything, but you should be aware that it's the dominant technique which makes a diagnosis. So for the central part, the transition zone, it's anatomy. For the peripheral zone, the dorsal part, it's diffusion, and for recurrence, it's contrast. And the new American College of Radiology guidelines on PIRADS, we work on it, will further describe these items. Soon to be expected at RSNA. So we do have traffic rules. Now everybody knows how he has to drive. However, we need schools to become a champion. Education. We need a driver's license. Certification. And finally, if you drive too fast, you get a double reading. Okay, quality control, very important. This will take a longer time, but this is our aim. We want to get the best technique available for patients. We should use internet. Radiologists can communicate by internet. I can read images of this guy in Brisbane, Australia. We have now contact with Los Angeles. And Madeline is sending data from here to Nijmegen during the night. My guys put it into the computer, and I read it this morning from here to Nijmegen and back again. And I'm sending my report PDF file from Nijmegen to Brad while I'm sitting in the same room. Moscow, Brisbane, Hong Kong, Pretoria. Those are the areas in which we have now are doing exactly the same as what we do here with Brad's team. Crystal ball, what's the future? Okay. Not really scientifically proven, but this is my view beyond the horizon. In the future, we'll have two cheap forms of MRI. Just like mammography. One for screening, no more than 15 minutes. And dear gentlemen, I can assure you that the screening prostate MR is much more to be preferred over a mammogram, where you compress the breast enormously, which is very painful, I've heard. Okay. And the prostate MR, we'll do it without contrast for screening. Just be on the table, relax, that's it. If you have a cancer, then you have a clinical diagnostic MRI, just like the clinical mammogram, ultrasound, MRI for breast. Screening with PSA and MRI will be introduced in the next 5 years. Combidex will be globally used. Where's Combidex? Come on, here's Combidex. And approved within 5 years. I'm optimistic. And, well, this is something new. It's not only Combidex, I always look at new things. This is the so-called 68 gallium prostate-specific membrane antigen PET-CT. It shows selectively, boom, tumor. There are some false positive areas, but if you now combine Combidex, the white dot here, with the green dot there, it's cancer. You can see this without these techniques because it's a big lymph node, isn't it, Joe? Now, Joe? Even if you put a circle around, it's even more clear. What about this patient? Nothing. What's that? A 3mm lymph node. Positive in both techniques. This now allows selective radiation. Merge the two informations and you can do selective radiation. This is the future. Okay. Targeted MR therapy. Local, laser, cryo, HIFU, IMT. Nodes, IMT. And it doesn't really matter whether you are, a uroradiologist or a radiourologist. Our professions will merge together. And I'm looking for collaboration, teamwork. What's the biggest challenge? Perhaps something for a discussion. To convince urologists about the value of multiparametric MRI, there's literature, or to make my colleagues aware competent. Question need to be answered. Global network, globalization. These are the centers which we have on the list. Some centers are already contracted. We need to create a global network of centers of excellences from where we can spread the excellent knowledge, educate. That's important. Los Angeles, Denver, Chattanooga, or Atlanta. We have already also here in Canada a site. Sites in Europe, Australia, Hong Kong, Japan, Rio de Janeiro. This is the future. Internet makes this possible. Put your software, because I was steering my software from a cloud in the cloud. You send your data with HIPAA compliant, anonymized to the cloud. You use my software and I can see what you do. Just like the apps from the iPad and the iPhone. Simple. Okay, future here in LA. I try to build up with this guy here, not only a center of excellence, they're getting there, but also a teaching center. And I hope that some other colleagues from other parts of the US and also from the area around, that we can work together in having the optimal education. University combined with entrepreneurship, combined with private practice. That's important. As a professor, you have learned to create new things, to validate techniques, and then you create new things. You validate, create, validate, create, validate. But what's more important is that we are using the validated techniques for implementation, and that's why we need those guys here. Okay. There's a lot of work to do for us. To conclude, this is not the beginning of the end, it's the end of the beginning. We and our patients have a bright future ahead. It is teamwork. Urologist, radiation oncologist, the CAT scan, and the medical oncologist is behind the cake. That's the mouse pushing the cake in the hands of the radiologist. So we need dedicated CATs. We need patient awareness, political awareness, and we need that guy. That is our multidisciplinary feedback. Urologists and radiation oncologists should demand for MRI indications. And they should check together with the radiologist if there is a good correlation between biopsy and pathology. And we should compare the outcome of individual sites versus center of excellence. Quality control. It's easy. And I think that's the future. Thank you for your attention.
Jelle, that lecture was fantastic. Now you know why Steve Jobs was to technology and Warren Buffett to business as Jelle is to our field, which is imaging the prostate. So I wanted to say how illuminating that lecture was, and I think you cut across from our patients all the way to our experts in the front, who I'm going to invite up to sit on a panel. And this evening we're going to have one of the leading surgeons in Los Angeles, Dr. Stan Brosman, who's a UCLA professor, to come and sit and join us up here. Dr. Brosman is going to be joined by Dr. Turner from the Pacific Radiation Oncology group. You come and join us as well. And all the way from south of the Mason-Dixon line, we have Dr. Joe Bush, an accomplished radiologist who's worked very closely with Jelle over the last few years, 3 years. And so for us, we took a team to the Netherlands to really learn how to do the pioneering work he has done. We have a lot more to do, but he's been incredibly generous in this teaching field that he's proselytizing with a passion. And fortunately, with technology being as powerful as it is, we've pioneered with him a way to have every one of our studies monitored and read jointly by our team and by his team, just like he pointed out, with a structured report, which we can assure the finest reading in the world with him. And I think this technique is going to emulate itself with a center of excellence with him in the middle in many different venues. So with that, I'd like each one of our panel to think of one question first that they'd like to ask Jelle, and then after he's answered them, each one, we're going to throw it open to the audience. So first, I'd like to ask Dr. Turner, from his perspective, he works with Mark Schultz, a radiation oncologist, and from your perspective, is there any one question you have for Dr. Byron?
Main question, so I'm a medical oncologist and we use this technology in our practice quite commonly, but one of the bigger questions is as far as the future for using MRI or multiparametric MRI for the diagnosis of prostate cancer, and what do you anticipate as far as the addition once we get onto fusion between MR as well as ultrasound?
Yeah, MR transfusion is of course very important, because if you want to replace the biopsies currently done by urologists with MR imaging and MR in-bore biopsy, we are not, well, we don't have enough machines, we don't have enough time. So also I think MR transfusion is very important to involve urologists in this fantastic technique. They need to learn how this technique is and how this will improve the outcome for their patients. That is very important. So I think it's a good thing that those techniques are developing. Having said that, you should be very careful to use techniques which are at this moment not yet validated. There are many vendors who want to push the market, who see the advantage of selling their tools to urologists and radiologists. But if you ask them, can you show literature? Can you show papers? Can you prove that your technique is as good as you promote the technique? The answer is sparse, and most of the times it's no, not there yet. There was one good paper in European Urology of Siddiqui et al., the group of Peter Pinto, experimenting with a prototype of the Euronav of Dynacat. They showed good results, but that's the only paper. And if you ask them, yeah, but how good are you in hitting the most aggressive part? That is still a challenge. If I would ask a radiologist, you have a CT of the pancreas in your upper abdomen, and you see a lesion, and you need to do a biopsy. You see it very well with this technique. Joe, would you use MR or CT transfusion in that patient? So you have CT, and then you use ultrasound, you merge the technique and stick in the needle. Or would you go for direct CT biopsy? I would go for direct CT biopsy. Having said that, we have limitations, of course. So I think what needs to be done is we need to evaluate and find out which patients can be done on the MR truss biopsy, probably the larger tumors. If you see a larger tumor anteriorly, you probably will recognize an ultrasound and you will hit it. But all the patients with pilot 4 and 5, read by good radiologists, who have a negative biopsy, no tumor, they should be back with MR-guided biopsy. So you should also have teams to do MR-guided biopsy. It's the same like breast cancer at this moment. So yes, MR truss is good. No, we should be careful. I hope that answers more or less the question. The other thing is, the radiologist is good in MRI, the urologist is good at ultrasound, and they're two separate persons. And if they collaborate, perfect. But if you give the MR to a urologist in his office without radiological knowledge, it may be a problem. And also vice versa. I was stunned a little bit. This week I visited one of the top centers in the US, and a urologist who was promoting MRI said, at my board exam 2 years ago, I saw the first MR image in my life. Okay. Education is very important. And I want to learn also the urologists to read MRs, just the way they are reading CTs. So collaboration, that's important. I hope that more or less answers the question.
Dr. Brosman, who's a leader of a big group here in Santa Monica and has a lot of experience from a surgical perspective.
There are many men who are being managed with active surveillance, and the numbers are increasing. If we have a patient who's been diagnosed with prostate cancer and is on the active surveillance program, can we use MRI adequately to avoid further biopsies? Because in the standard protocol, the man would be biopsied either 6 months after the initial biopsy or 1 year after the biopsy and 2 years after that. Can we eliminate some or all of those biopsies?
The answer is yes, we can eliminate many of the biopsies, especially truss biopsies. If you're under active surveillance and the MRI doesn't show anything because you have insignificant cancer, you need to use MRI to select patients, by the way. So you have a negative MRI, you just happen to have a diagnosis of Gleason 3+3, minimal tumor, repeat the MRI in 1 year. If it doesn't change, and radiologists are very good in comparing two images, We are very accurate in seeing the differences. If the T2 doesn't change, if the diffusion isn't restricted, go home, be happy, come back next year. Only a 20-minute exam, no needle. However, if something changes into the wrong direction, you should hit the tumor with a very precise needle, either with direct MR bore biopsy or with MR transfusion. So you need a biopsy when the MR changes. The chance that you will develop a significant cancer on MRI which is missed is extremely low. So if I would be on the active surveillance, hopefully I will not, then I would choose for MR imaging. The other thing is that if we are using MR in the future to detect cancers, the number of insignificant cancers detected will go down. So I think the number of patients which are under active surveillance will go down in the future. That's good. Perhaps not for your business as medical oncologist, but good for the patient. You don't diagnose the insignificant cancers as much anymore. I do not know whether you agree with this statement.
Well, yes. Well, of course, there's a follow-up question, and that is, how many radiologists would need to be trained in MRI to do all of the MRIs that you suggest are done?
A very good question. It depends, of course, on the number of patients. In our institution, we can read 2,500 MRs. It's no problem. And I did it last year with 2 colleagues. So, and it's a part-time job for my colleagues. It's a full-time job for me, beside the time that I'm traveling around. So, effectively, I think only 1/3 of the time I'm reading. But you can do many prostate MRs in your center. And the thing is that you start as a center of excellence, and then you become a reference center, and you teach centers around. And we should be networking. We should be networking with Bob Princenthal. We should be networking with Joe Bush. We should be networking with others to spread this knowledge around. To answer the question, right now, we are not there. We don't have sufficient capacity. However, I'm sure that if you refer patients to Brad, or to Robert, or to Joe, or to Nijmegen, that we will create time on the machine. So the answer is yes. We will follow your directions, but you have to ask this question. I want an MRI today, and he will give it you probably today plus 5 minutes.
Yeah, and I think to amplify that question, it's not only the radiologist, but you can have very good radiologists, but the machine isn't up to par. So standardizing all this is similar, as Yeli said, to mammography 20 years ago when women, the tragedies of mastectomies and everything that went on, but then the standardization that came and the insisting on certain quality that brought mammography and women's imaging right up to a new standard is what I think Yeli as a pioneer, bringing center by center everybody up to his high level is what we're going to help him with.
And the American College of Radiology will have the requirements, the minimal requirements for prostate MR. If you don't fulfill the requirements, you have a problem. You may not even be reimbursed by the healthcare providers. That's what's going to happen. Yeah. We even had a discussion with diffusion-weighted imaging. There is a certain machine which is not as good as diffusion-weighted imaging as others. And within the American College of Radiology Pilots Committee, we had a discussion. Should we lower our minimal requirements? We said no. We have a baseline minimal requirements for prostate MR. In the Netherlands, I succeeded in getting into the Dutch guidelines MR, provided that it was done with the ESUR guidelines. And those are the European guidelines. And they will be similar to the American guidelines. So, yeah, I completely agree.
So part of bringing Yeli here is to create a reference center where we can teach using his techniques at our facility, creating a center of excellence and bringing in our colleagues, sometimes our competitors. But we really are working all together for the patient. So knowledge should diffuse through the community.
And it's not me who will be reading all the prostates. I hope that in half a year you'll be reading your own prostates so that I don't have to read.
Well, it's nice to have a double reading.
But double reading will be done. Quality control will be done. One out of 10 cases we randomly will choose. And perhaps we even should do double reading.
But that was what the model was for mammography, where you had two mammographers reading, two excellent mammographers reading the same image ends up with a better report. So we're already there, and although we've got Yeli at this level and us at this level, the final report is still, I think, a strong report.
Yeah.
Third question would be from Joe, who will come with a tricky one, I'm sure.
Joe, you're positive on MRI. Now try to ask a negative question.
So, Joe, let me ask you this. What has been your biggest hurdle in becoming really as skilled as you are at reading MRI of the prostate?
That's a great question. I guess it's the biggest hurdle is time, because I do a lot of PET-CT imaging, and I do a lot of other cancer imaging, and as Yeli said, you really have to focus on this, because I think the learning curve is somewhat steep. And in our group, we only do highly specified reading. We don't, everybody, like even though we have 10 physicians, only 2 read MR breast. Even though I think I could read a breast, I do not read MR breast. So I think it just takes time to get good. You have to look at a lot of cases. I think you should go to the pathology department and review the glands and look at the glands that you looked at on the machine before they came out of the patient. And I think that's the best way to learn, I think, at first.
And that's true of any new.
And then I spent a lot of time with Dr. Behrens. I mean, really the reason I know what I know is because of Yeli Behrens and his team. There's no question about that. And I've been very fortunate to become his friend, and so therefore I know a lot of things that are not in the literature yet, but they use every day in interpretation. And I think that's the important thing. One of the things I like about it, because I haven't, is that I'm a real doctor again. I interview the wives or their girlfriends or their boyfriends when I'm in my office, as Yeli Behrens does with the big TV, and go over their cases. It's really fun. It's really nice to practice medicine again. And I think you do make a difference, Yeli. I think I've seen it. It's a big difference. I was telling Dr. Bozeman, we've canceled 3 radiation therapy treatments that were planned, went back to my oncological urologist who I work with, and in order to prove this, we had to resaturation biopsy, but all 3 of those patients they couldn't find any cancer on the saturation biopsies. So they canceled the radiation therapy treatments. So those patients gave me a hug.
Mm-hmm. Now, do you have a question for Yeli?
Yeah, I have a question for Yeli that kind of tacks on what we were talking about. And that is, number one, we haven't told the audience, number one, what is the significant size? Because I think this plays a role with fusion. Because I've seen some high-grade tumors that are 4 and 5 millimeters, and I think I have no experience with fusion ultrasound on that, and I think, like, as you said, I think there's going to be specific what to do that. And then also I'd like to know, I've got hundreds of people on surveillance now. Out of 100 men that documented 3+3 by the current criteria to do active surveillance, do you have a feel for how many of those people may convert when they come in after the 2nd or 3rd year for their manogram, and we see them change? A number, because I have a number, but I'm wondering what your feeling is.
To start with the last question, first of all, I think that if you talk about patients who had an MRI screening, or talk about patients who had just a trust biopsy?
They had a trust biopsy. They're proven 3+3. I do the MRI, and I don't see, quote unquote, a significant cancer. I give them a 1 or a 2.
Okay.
And I'm going to follow them I'm going to follow them next year.
Okay, so first of all, if you do MRI, you have a fair chance of 20% that you have an upgrade with MR. But let's assume you have a Gleason 3+3. The chance that you develop a cancer within 5 years is very low. To be sure, I think it should be advised to do a yearly MRI. We still have to learn. That's what we did with breast cancer. Based on the outcome, we can then perhaps do an MRI once in 2 years. But I should start with an annual MRI. It's just a 20-minute, 30-minute exam, and you'd rather detect a tumor in an early phase when it's going to migrate, change from a 3+3 to a 3+4 or 4+3. So I would do it on a yearly basis. The second question about the tumor, does volume matter? I know that now perhaps I'm just cursing in the church in front of a urologist. I think volume is less of importance than aggression. Having said that, we have difficulties in detecting 3+3. That means a non-aggressive tumor. Even big ones we can completely miss. The question is that really bad? The other thing is we really are good in showing high aggressive tumors. Even when they're very small, we have detected 2 to 3 millimeters small Gleason 9 and 10 tumors. That is possible. Why? Because the ADC is so dark that within the bright peripheral zone, you will be able to see the tumor. But to see the tumor and to hit the tumor is something else. And that is a challenge. I think small tumors which have a size of 5 millimeters or even 6 millimeters and less, I would prefer to do them under MR guidance, direct in the MR bore. If the tumor is large, and I'm talking about the most aggressive part, so the diffusion abnormality, I think we should biopsy not the T2-weighted image, but the diffusion abnormality. If the tumor is larger, I think you can do it safely with TRUS MR fusion. Still, we have to learn a lot. I think we should do prospective studies comparing both techniques. Having said that, if you have a 4+5 tumor, even a small one, if you don't have positive histopathology, so no cancer, repeat it, repeat it. I can't emphasize that more. If you have as a radiologist, well, let's assume, Brad, you're learning prostate MR. At this moment, good diagnosis, good technicians, and then you do the direct MR biopsy, and your pilots 4 and 5, you only have a hit rate of 60%. Then I will knock on your door, say, hey, Brad, you miss 40% of tumors, so why is that? Is your diagnosis wrong? Do you do a wrong biopsy? What's wrong? So I think that is important. And the urologist should be able also to say to Brad, hey Brad, you're missing too many tumors because that cannot be true. You should know that the pilots 4 and 5 should be cancer, period. And if it isn't a cancer, you either read the images wrong or you do the wrong type of biopsy. The same is true for urologists. So I think that's a learning process, which is a nice future. I really look forward to it.
Along that question, how soon would you bring back, for instance, I have a patient that I'm sure they have a 7 or an 8, and I stuck them and I got a 3+3. I think I missed it.
Yep.
How soon would you rebiopsy that patient?
As soon as possible.
All right.
Yeah, and because you are missing a significant cancer.
Well, that's my opinion on the images, but.
Yeah.
And,
yes,
and now I want to invite the audience to ask questions. Dr. Cohen, yeah.
You said that about 2% of the pyrite 1 to 3 would be positive for malignancy. That's significant. Is that correct?
Yes, in the trial I showed to you, we missed 5 very bad significant cancers with the combination of MR imaging and MR direct biopsy. Only one of them was a pyrite 1 to 3. That was a mucinous carcinoma. That's a cancer with a lot of fluid, and it's very difficult to recognize those tumors from normal tissue. Perhaps with growing experience we will. I'm collecting now those tumors, so if any radiologist has a mucinous carcinoma missed on MRI, please give it to me because we need to write an editorial on that or an educational paper. The other 4 were pyrites 4 and 5, which were negative on biopsy. And did not re-biopsy because the protocol did not allow. So I think, again, that emphasizes the fact, never trust a biopsy on the pyrites 4 and 5 lesion.
So the question I have is, if you have this mucinous carcinoma that you developed, that you discovered, was that a pathologic diagnosis from a prostatectomy specimen, or was that a biopsy specimen?
That was a biopsy specimen from TRUS. So TRUS detected the tumor and MRI did not. Just by chance, at random biopsy, the patient was just lucky that with TRUS biopsy, it was in the middle of the mucinous carcinoma.
So did the urologist send you the patient with this mucinous carcinoma to have the MR? I'm sorry if I...
No, it was the trial. The trial was designed that every patient with elevated PSA had a thrust biopsy 12 core. And in addition to that, they volunteered to have an MRI, completely independent, and a completely independent MR biopsy if the biopsy was 4 or 5. And then you look at the results, what comes out of thrust and what comes out of MR. We did not do prostatectomy in all those patients because there were 50% of patients without cancer. You can't do prostatectomy in those patients. We consider that unethical.
So when you biopsy those patients with MR,
yes,
were they sedated?
No.
Because if your margin of error is like 2 millimeters,
yep.
and these people are breathing and moving,
yep.
sometimes it's very hard to hit
yep.
the target.
That's good. Yes, you're right. However, we always make a confirmation image with a needle in the prostate. So we know where the area is, and all the images post-biopsy are being read by experienced radiologists, by me, and I look, is this biopsy representative? Yes, perhaps no. So you can read the image and you can see on several cases that you just missed the tumor, and then we do a rebiopsy.
So it's a dynamic image that you see? So
it is an image where the needle is in the prostate. You can see the needle, which is dark on MRI, and you can localize the tumor based on the other images. You superimpose them, and you say, okay, now this is the right position. And you look in 2 planes, so you don't need dynamic images. So you look at the sagittal plane and the axial plane. We always make images in 2 planes. So then you can be pretty accurate whether you missed the lesion, yes or no. And that is what I would like to emphasize to all radiologists. Joe?
Yes, sir.
Yeah. If you do an MR biopsy, do you make confirmation images?
Absolutely. I confirm them in 2 planes. It takes me, Yeli had explained the technique, it's a 10-second shot, and it takes me about 20 minutes to biopsy somebody.
Robert, do you take confirmation images? Most of the time. Okay.
I do it all the time.
I really would like to stimulate you to do it all of the time.
All the time.
Probably big tumors you don't do. So that is important. We need to teach our radiologists, if you do MR biopsy, make confirmation images. Preferably under ultrasound MR fusion, make confirmation videos, do the interpretation so that you always can localize where you were if you need to come back to the same patient. Yes, they are transrectal biopsies. And you also, well, of course, you do have the potential complications which you have with thrust biopsy. That means sepsis, fever. We've seen it with MR. Number is slightly lower because we use lower needles, but well, whether you use 1 or 10 needles, if you have feces into a prostate, you may have sepsis. The question is, should we stay away from the rectum and should we go to the perineum? It's a very direct approach. You're very close to the tumor. The needle is very close to the tumor, so it's very precise. I know that the group in England, of Mark Emberton, they're doing the transperineal approach with MR, focused with MR thrust fusion. So that would be an option. We need to evaluate what's the best. And it depends also on the sepsis rate. Sepsis rate is increasing. Probably due to the fact that we eat the wrong type of chicken or we wash our hands with all kind of antibacteria, which is cross-resistance. In Asia, people are taking Cipro. They get it at the grocery store when they have diarrhea. So the guy in Australia is using 2 antibiotics with his biopsy. Nonetheless, with the thrust biopsy, he had two sepsis. With MR, no. Okay. Yeah.
We have many patients who have pacemakers.
Yep. Yeah.
Is there a good correlation with color Doppler ultrasonography with contrast and elastography?
Very good question. Recently, we revised the guidelines in my country, and we had to give an advice of power Doppler ultrasound, contrast analysis, ultrasound elastography, and histoscanning. And there's at this moment not enough evidence that these techniques are good enough as MRI. Yet there's no proof. With power Doppler and with enhanced Doppler, so with contrast agents, you see vascularity. And vascularity with MR, the DCE, is the least important technique to grade and detect aggressive tumors. You may see enhancement in BPH, benign prostatic hyperplasia. You may see enhancement in prostatitis. You may see it in cancer. So with power and color Doppler and contrast enhanced Doppler, it will be the same. Elastography is just the urologist's finger with a sophisticated technique. You feel the prostate and you feel whether there's a stiff area. You see whether there's a stiff area. It depends on the pressure which you probe, which you are performing, what the signal is, which comes back. So if you press a lot of signal comes back, so that makes it operator dependent. If you have a probe which is having a pressure which is independent of the urologist, so a vibrator or something like that, it would be good. Histoscan has been proven to be not as accurate as MRI, period. The other thing which I should warn urologists when they do MR transfusion, please, dear colleagues, only biopsy the lesion which is significant on MRI. Don't do a random biopsy in addition to that lesion, because why don't we have screening at this moment being advised for? Because of overdiagnosis. That's even worse than undergrading. And that's of course the risk. If you give an MRI to a urologist, I was taking another few needles just to be sure that I don't miss a tumor. That's so human. So don't do it.
Is there one more question from the audience?
I'll take one. So what I'm hearing,
Yes.
I'm trying to put on my medical model background and my business background, and fusing this question together, my question might be to all of you, what's the barrier to entry to getting more urologists using this type of care? I know from my experience in the healthcare field, we tend to kind of rely on what we already know, rather than, well, that test is just the same as this test, so I'll just use mine, and so how do we move this conversation forward?
Okay, perhaps we should start with the leading urologist to answer this question.
Well, the barrier is huge. For example, you talk about fusion. Where's that available? You know, I mean, that is so limited that you can forget about it.
And the price is quite
now,
high.
huh?
And the price is quite high.
Yes, well, it's not here. We can't have it. And we have no idea what the cost would be, the reimbursement would be. So we're a long way from getting to that. Now, the other part of your question relates to do the institutions have the right equipment? Because it's one thing to teach the urologist to say, yes, you ought to get an MRI on everybody prior to doing a biopsy. So we think that's state of the art. But if they go and have the imaging study done at their hospital because they happen to have an MRI unit, that is not necessarily state of the art. No, the institutions have to step up. Now, granted, we're talking tonight about establishing centers of excellence, but these centers of excellence have to be integrated with the hospitals, the radiology departments. Freestanding centers of excellence will not do the job because the hospitals want the work. And are they willing to invest in obtaining the equipment? Are they willing to train their urologists or partner, which is even better, with others? Is a whole new dynamic. You know, I don't know of any partnering going on in Los Angeles County with a private institution and an imaging center, do you?
Well, I have a slightly different take on that. I see hospitals as 19th century institutions because they were developed as places to get people out of the community when there were infectious diseases, where religious orders took care of people, and then it evolved into you know, a place where everybody thought this is the only place you can get your medical care. I think hospitals are places where tertiary medicine is best done, heart transplants, liver transplants, but the move has to be, in order to have a really egalitarian medical system that supplies good care to everybody outside of the bureaucracy, because hospitals are just hidebound and cannot function in a flexible and quick way that really moves to the patient's best interest. So we really have to create a new paradigm, which is a political, business, academic partnership where, and you might say we're moving in the wrong direction in the US, where we're moving towards a massive bureaucracy, and that's a whole nother debate. But given that that may happen anyway on a big level, there's still going to be tremendous need for flexible and very pioneering private facilities and cross multi-specialty lines where that connection happens. That is the future for excellent medicine. The rest is going to be very average medicine, and that's going to mostly be in the hospitals.
First-hand example of exactly what you were talking about. In my city, I put such tremendous pressure on the main hospital in the city when they started finding out what I was doing. They adopted MRI with a 3 Tesla, a very similar machine to what I have. They got the same software, they got the same biopsy device, and it's very interesting. As of 2 years later, now all the urologists this last week, they sent me about 3 patients. They can't get the job done right, but there are very multiple reasons for that, but they're really failing at doing what they're doing.
Yeah, and I mean, it's
and
a radiologist
everything
has
you
to
said
be,
exactly is what they are doing, exactly all the mistakes.
There are exceptions. I mean, Yeli is an exception because he's in a European system where you really have a different culture of medicine in many ways, where he acts as an entrepreneur really, but without the financial burden of having to worry about anything. But he thinks like an entrepreneur because he wants to be the best at what he does. And that culture in the US is different in that if you're in a hospital, you've got union employees, you've got the radiologist who cannot tell the tech what to do. The tech says, I'm not doing it like that, talk to my supervisor. So you might end up with a very good machine, a very good radiologist, but everything goes sideways. And so whether it's Cedars-Sinai, UCLA, St. John's, it's the same issue. If you talk to the radiology departments, it takes a lot of effort to get to the frontier. That's the answer.
So, can it ever happen?
It can. There are great academic institutions. Some people in this audience could talk to this. Vinay, how do you feel about that? He's head of body imaging at USC, which happens to be a very entrepreneurial and I would say forward-thinking institution.
Absolutely. I mean, it's a combination of both systems. You can be excellent in some aspects, and it depends on the team. If you have a brilliant examination, but you don't really have the right customers, you don't have a team of urologists, medical oncologists dealing with that you're not subscribing to anyone, you're not providing a service to anyone.
The mission of an academic institution should be like a priest or a Talmudic scholar. They must go and get the information, they must validate it, they must study it, they must give us the truth, and then they must get out of the way. Because delivering to most of the public, the democratic citizens of the United States, cannot be done by a big hospital. That medicine on the frontier cannot be done by these giant hospitals. It'll only result in Soviet-style bureaucracy.
I'm Ante, so I wanted to give an example from another country, from England. I happen to be at New Ada Medical, which is an imaging center dedicated solely to prostate health in London just a few months ago, and to actually have MRI for one of my patients there. And it is totally private, established by an entrepreneur actually who is non-physician, financed the whole facility, and it's on Harley Street, if you know. That's where all of the private institutions in London, or many private institutions and doctors are based. And when I had a chance to interact with a managing, whoever that was, director, who was not a physician as well, he was so enthusiastic, and he reported Bupa, which is the biggest British private insurance company, is covering MRIs right now. MRIs of prostate and prostate-guided biopsy, because Bupa is obviously counting money. They realized that they saved lots of money by covering prostate MRI and guided biopsy versus traditional approach. And this is, of course, in a country where, you know, there is a national health system. So,
what you're saying is that it's a private vehicle doing dedicated urological and prostate imaging outside of the NHS.
Totally outside national system. It's financed by an entrepreneur. I don't even know his background. I think it was software. And of course, he was able to engage top radiologists, whom I think Dr. Behrens knows me very well. Actually, he directed me to that center.
I had a discussion.
So that's a great example. I think it can be done here. It's been done right now.
Okay, thanks.
Dr. Jabur, right?
I had a discussion with the same man just a few weeks ago. I can mention his name. His name is Brian Lynch. He's an entrepreneur. And what he's doing is just establishing centers of excellence in prostate imaging. And he thrives, and he will, I think, will be able to achieve that within 1 year, to do 10,000 prostate MRs with his groups of center of excellences. One of the leading radiologists is Andrew Padani and Alex Kirkham. And they actually prove that there is a bright future for specific centers which just do prostate MR and MR-guided interventions in MR biopsy. They have a very good collaboration with urologists. They have a very good referral rate. Having said that, looking a little bit in the future, mammography in our country is being done in trucks. So you can put a mammogram in a truck, and then we can come to your doorstep to do the mammogram. They usually have a pink ribbon, so why don't we put an MR on a truck? That's also possible. Yeah. You can just drive around with an MR and do screening MR. So yes, I think you can stay out, and perhaps we need to stay out of the academic environment. I'm an academician, and I completely agree with you. My task is to innovation, validation, and then give the techniques to the guys who implement it, like Brian Lynch, like you, and others. For that, I want to have a little bit money back. It's not for free, and I don't want to use that money for myself, but to create new innovations, because the research money is really, really very bad at this moment. So I think we should collaborate.
And I think our urological colleagues have to be the captain in many ways. We are loyal servants to you, Stan, and your team. So we have to get the urologists on to the same wavelength as a win-win. I think that's going to be the trick. How we do that, it's probably going to take a half a generation to get the next group of trained young urologists who believe in MRI.
Well, sure, but look at the challenge. Joe just told us about the resident taking the boards at a very prestigious school who had never heard about it, and you could multiply that by some large number. Yeah. So,
but you're very early adherent to MR. What was it that made you, as a, you know, the guys just coming out of training are more rigid than you are, which is interesting. So you can help us understand what thought process did you go through?
Well, sure, you have to have an interest, but we also had a very good center at the University of California in San Francisco. Yeah. And Kerhanowitz, who is still there, you know, was the early person, and we knew what the work that was going on, and we were actually sending patients to San Francisco for those early studies. And it was clear that there was going to be an important future for this technology. Well,
but let me ask you a question. Why doesn't that knowledge which you have and which is there, literature which is there, why isn't that more distributed among urologists? I was really surprised that this urologist heard about MRI just only 2 years ago. We are living in a world with communication, with papers. I don't know how the US papers are, but European urology is full of MR papers which address the value of MR imaging. The chairman of the EAU had made a statement recently at a meeting that he said, well, MR imaging will change the practice for urology forever, screening will be a possibility. So how can it be that there are individual urologists in 2012 who haven't heard about MR imaging? And what should we do to, what can I do more as a radiologist to spread this news around? Because I think it's a pity. We have a diamond in our hand and do something. Make something nice. So,
poor Stan, he's one of our allies in many ways, but he has to answer for his whole
Sure, but
group,
keep in mind, you take a residency in urology to learn how to operate. All right? That's number one. Yeah. And you better be good at it at the end of the residency. So your skills in radiology are very limited. Yeah. I mean, you can throw up a CT and figure out what it is and so forth. But that's it. Now, should a part of a rotation be in prostate imaging? Well, probably so. That would be very helpful.
Or interventional radiology in prostate.
Yeah.
That would be very nice. So my statement was a uroradiologist or a radiourologist. That would be very nice if we could work.
That's right. So should there be fellowships in for urologists in imaging?
I say that the prostate and the brain are very similar. They look similar, believe it or not. There's a peripheral zone and a central zone, gray matter, white matter. They don't move much. Both the brain and the prostate doesn't change with respiration. And if you take the neurosurgical approach, most neurosurgeons actually spend active time with the neuroradiologist doing the interventional procedures. And we collaborated in fellowships, neurosurgery, neuroradiology, very closely. And so closely, in fact, that neurosurgeons wanted to take over the whole of neuroradiology. Thank goodness there were other skills relating to MR that they couldn't quite get their head around. But it was a true collaboration. And I think you could not do neurosurgery today unless there was almost this team effort, neurosurgery, neuroradiologist. And I think that's the model we should be thinking of with urology. And I think it would enhance everything, and especially for the patient. Yeah, that would be the vision, I think. I think we've exhausted everybody. Thanks to everybody, Bob, and all our... Thanks very much for coming, everybody.